country, there is 3 times the higher risk of a woman dying because of these problems than a woman in the West. So we are very now proactive about trying to screen for preeclampsia or for hypertensive problems in the first trimester itself. These are the sort of variables we use. So if one looks at the study of 2009, which looked at several thousand, again, women coming out of the Nicolaides group about preeclampsia, and we are looking at the fact that we took the a priori risk as the background risk, the prevalence of the disease in the community, and looked at the uterine artery performance. So this is normal. This is the performance to pick up early preeclampsia, the mean arterial blood pressures, the PLGF, and the PAPE. So on its own, the biochemistry does not perform very well. It is okay. But together, so if, again, looking at PAPE over here, you can see that it's much lower when there's going to be an associated pregnancy problem. So on a PAPE, maybe if I pick up preeclampsia before 30 weeks, so it's 56%. If I add PLGF to it, I will make it about 69%. So it improves the detection rate by about 6%. But much more important than that is the fact that it gives us a clue about this woman going into an adverse pregnancy outcome because of the fact that it flags up these problems. So we flag her up and we sort of make sure we monitor her much more closely than we would other pregnancies. But anyway, much more important than that is the fact that the other biophysical variables, like mean arterial pressures, where in the olden days we would look at systolic and diastolic blood pressures, but now we know very clearly that the mean arterial pressure is much more sensitive at picking up hypertensive problems in pregnancy. And there is a protocol on how it should be measured, as you can see over here. It has to be both arms. It has to be done repeatedly so that the systolic measures the difference in measurement is less than 10 millimeters and the diastolic is less than 6. And then we measure the uterine arteries because, again, this gives us the higher the resistance, the greater the chances are that this woman will end up with these kind of problems. And we put everything into the FMF preeclampsia software, where we put in the maternal demographics, we add the blood pressures, the uterine arteries, the PAPE and the PLGF, and the software gives us the risk of this woman ending up with a problem. And this, again, helps us in triaging people. So this is how the report comes out. We give risks for aneuploidies, we give risks for preeclampsia, we give risks for fetal growth restriction, and we give risks for preterm delivery as well. So for us, at the end of the scan, we've given risks for maternal conditions. We've given risks for structural abnormalities. So when we say that this woman is fine, we really reassure her to a huge degree. And this is what is important for us to do at the 3rd month. So all of you have to join in this endeavor in pushing the first trimester screening forward. This is just a slide to say that in women whom we find a problem, we start low-dose aspirin. So in this very busy slide, it's kind of telling you how preeclampsia performs if we sort of use the various parameters. And as you can see again, if you do a uterine artery PI, the mean arterial pressure, the PAPE and PLGF, it performs the best. It picks up 93% of women who are destined to deliver before 34 weeks. We again looked at our own data. Our sensitivity was not so high, but the specificity is very high. So even if we may not, so when we reassure these women, when the uterine arteries are fine, the PAPEs are okay, the mean arterial, we are very confident in saying that no, go away, you won't have a problem. But in our screen positives, the sensitivity that she will actually go on to have the problem is much lower. But it just means for her, it means that a few extra scans and that she's monitoring her blood pressure much more regularly and that she's been started on low-dose aspirin in the first trimester. All of you, just to finish off, all of you are aware that now where technology has moved forward is in non-invasive prenatal testing, where it is possible to look at the placental trophoblasts and extract them because of these molecular the next generation sequencing techniques, where it is possible to give risks for trisomy 21 just based on maternal blood, and that is coming in now. So I feel, you know, 10 years from now, that is going to be the best screening test, because the detection rate is so high for a very low false positive rate. But will that actually mean that we won't do the nuchal scan, or we won't want to have PAPE measured? It won't, because all of these components are important to give different informations. So we would still want the PAPEs to give adverse, you know, to assess and give adverse obstetric outcomes. We would still want to do the nuchal scan, because the nuchal scan is not just aneuploidy screening. It highlights a lot of other problems, and for us to do an early anomaly scan. And we would still want to, of course, do the NIPT, because that's the best test in the, for doing aneuploidy screening. So thank you all for a very, for your attention. Thank you.
Can we have a round of applause, please?